Two, one. Please start, sir. We are live.
Thank you. Uh, Very good evening to all doctors and our speakers. So my name is Vinod from Kerala. On behalf of Bayer Pharmaceutical Private Limited, Oncology Division, I would like to thank all the doctors who have joined the meeting, even the busy after a busy schedule. And we have three eminent speakers who are going to talk on three different like topics like Arason's trial, Arana trial, that is with docetaxel and without docetaxel, and we have another doctor who will be presenting on the case presentation. That is a real world case study. So without much wasting time, so I'd like to welcome Dr. Saurabh Misra. Doctor is director and head medical oncology and hematology, Tender Palm Super Specialty Hospital, Lucknow. So Saurabh will be talking on Aronaut evidence, that is darolutamide without chemotherapy. So over to you, sir.
Yeah, yeah. Just wait. So I think my slides are visible.
Yes, sir. Visible, sir.
Yeah, right. So thank you, Bayer team, and good evening to all. And this is today's discussion will typically focus on that. Uh, let me first. So it's yeah. So today we are going to discuss about the metastatic hormone-sensitive prostate cancer. So before my lecture or my talk, there is a whole sum of MHSPCVI, Dr. Nikhil Haridas, because of some busyness in the work, he is not able to. So I'm going to share my thoughts on this because of this new molecule that is darolutamide. Not new, no, it's more than a year, I know. And it is what is its recommendation in hormone-sensitive prostate cancer, and definitely the evidence of ERA note trial I will show. So before presentation, this is a disclosure, and that is a disclosure given by this means by the Bayer team as well. The important point why I have gone that in India, approval status of available second generation androgen receptor inhibitors is darolutamide is approved for treatment of non-metastatic CRPC patients and metastatic hormone sensitive prostate cancer in combination with docetaxel. So with chemotherapy, it is recommended in NMCRPC, that is non-metastatic, and metastatic hormone-sensitive prostate cancer. Darolutamide is indicated for the treatment of patients with metastatic hormone-sensitive prostate cancer. So basically, it is mainly recommended in hormone-sensitive prostate cancer. In CRPC, there is one setting that is non-metastatic. We see in the our clinical settings most of the time these type of presentation also. So before going to, we should have some chronology. If you see that how the standard of care in metastatic hormone sensitive prostate cancer has evolved to combine androgen deprivation therapy with AR inhibitors, abiraterone or docetaxel. So there's a long history if you see, and the landmark trials were there, Charted and Stampede. And here the Stampede arm C, here they have used the chemotherapy with ADT. Stampede arm G, they have used as abiraterone plus ADT. So if you see the chronology, from 2014, first time the Charted has the docetaxel plus ADT has been, you can say, published and approved. In 2015, the Stampede Arm C has proven the docetaxel plus ADT. So for chemo plus ADT, we have a two evidence from Stampede Arm C and Charted. Coming to 2017, there is a Latitude study where abiraterone with ADT has been approved in this setting also. And in MHSPCC, basically 2018, Stampede Arm G has proven the same Latitude strategy, abiraterone plus ADT. Coming to 2019, if you see that Titan trial, that is the one more AR inhibitor, eplutamide plus ADT has been approved. Coming to move forward, 2021, if you see, there are, this is a combination of abiraterone plus ADT plus chemotherapy has been, plus minus chemotherapy has been approved. In about the enzalutamide, there are two trials, that is Archies and Enzamet trial that has been proven with the ADT as well, ADT plus minus chemotherapy. So if you see the chronology, all the molecules in pipeline are there and they have been proven with at least two evidence studies are there. Coming to the darolutamide, where Arasen's trial in 2022, first time it was recommended with the combination of ADT plus docetaxel. In 2024, ARANOTE has shown that it can be combined with ADT, and in Erasec also, this darolutamide has been combined with ADT. So there are two evidences in 2024. So we are going to discuss here the ARANOTE. I think after me, other colleague speakers will get you in a great detail of these studies, most probably. I am focusing on ARANOTE, and there is a case-based panel discussion as well that will explain more real-world scenarios. So, what is unmet therapeutic need right now, if you ask me, in the prostate cancer setting in HSPCC? So, in unmet medical need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with MHPCC without adding significant toxicities and with a low drug-drug interaction potential. That's what the unmet need can be said. So, Erasense, that is a phase 3 study that has been combined with docetaxel, already showed beneficial efficacy and safety profile in the MHSPCC patients, leading to its approval in India in 2023. Now, darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic hormone-sensitive prostate cancer patients, as demonstrated in the global phase 3 study ARANOTE trial with significant Indian patients. So there are a few highlight points that have been shown here. With the ARANOTE data, darolutamide has the potential to change the treatment paradigm, as now it would be the only ARI which could be used with and without chemotherapy. This is what the evidence shows here. Okay, so if you see the background here, darolutamide plus ADT with docetaxel is a standard of care for MHSPCC. In Arasense, darolutamide plus ADT plus docetaxel demonstrates favorable efficacy and safety versus only ADT plus docetaxel in patient with MHSPCC. ARANOTE was designed to evaluate darolutamide plus ADT versus ADT to provide a new treatment option for MHSPC without docetaxel. So that has been shown here. So if you see the trial schema of ARANOTE study design, it's a randomized, double-blind, placebo-controlled phase 3 study. Open label was double-blind phase was in the initial phase. Open label phase was until the final analysis. If you see total, if you see the inclusion criteria, 665 patients were there, MHSPCC there, and their metastatic disease confirmed by conventional imaging method, either by a positive bone scan, technetium 99M bone scan, or soft tissue or visceral metastasis, either by CCT, pelvis, abdomen, and chest, CT or MRI scan assessed by the central review. So one point to be noted, I think PSMA PET CT was not utilized here for the staging workup. Histologically or cytologically confirmed adenocarcinoma of the prostate, ECOG performance status relates from 0 to 2. The patients has been stratified according to the visceral metastasis and prior local therapy, whether it was given or not given. So here the darolutamide 600 milligram twice daily plus ADT, 2:1 randomization with the placebo. Primary endpoint was radiological PFS. Secondary endpoint, the OS. It was a key secondary endpoint. Time to initiation of subsequent antineoplastic therapy. Time to CRPC. Time to PSA progression. Rate of undetectable PSA, that is less than 0.2 nanogram per ml. Time to pain progression. Safety as per the NCI CTCAE version 5.0. Other pre-specified endpoints were PFS2, time to secondary events, second infection events that happens, time to detection of FACT P total, time to prostate cancer invasive procedure, all are there. So there, if you see the open level study was there because now the investigator as well as the patient were all aware what treatment they have been given, and 100% crossover to the open level darolutamide was there, and selected endpoint was OS and safety in the final until final analysis. Data cutoff June 7, 2024. Median follow-up for darolutamide group was 25.3 months, placebo group 25 months. This is all the in detail the trial schema. You can see how the things has been designed and what are the primary endpoint and the main key secondary endpoints if you see. So coming to next, if you see the patient's demographic and clinical characteristics at baseline in both the experimental arm as well as in control arm, they are being well matched. They have randomized in 2:1. In that way, they are well matched. If you see that in terms of performance status, in terms of Gleason scoring, in terms of serum PSA at median range, median metastasis at initial diagnosis, disease volume. So there is 70.6%. If you see the 315 patients out of that were a high volume disease. So high risk patients were also there. De novo cases were 317. And if you see visceral metastasis patients, there were 11 patients, 11.9% with the visceral metastasis as well. Prior local therapy, no patient, most of the patients have not taken prior local therapy. Most of the patients are the de novo, that's why. So this is what the baseline characteristics has been distributed, and it is well matched in both the arms. So if you see that country representation across breakthrough clinical trials for prostate cancer treatment in various ARIs that has been approved. So in Cougar AA032, QCOU AA03312 for abiraterone, if you see the distribution of the trial countries in that has been marked with the violet, you can see that the most in the ARANOTE trial, Asian patient, 30% patients were there. In rest of the other trials like Vision trial and Embark trial, Asian patients has not been included, but here 30% patients are the Asian. That is, you can see in the map, they belong to, I think, India as well, China, and you can say there are patients from both the countries here. Latin American patients were there in Europe and rest of the world, 41%. So it's a good inclusion criteria that can be replicated in our real practice also. So that's how the distribution was there. China 65, 14.6%, India 13.7%, Taiwan 3.4%, Australia 4.7%, New Zealand 2.2%. So now this is the time to see the curve, how the darolutamide plus ADT significantly reduce the risk of radiological progression or death by 46% versus placebo plus ADT. You can see this curve is separated, and here a median was not reached in the darolutamide arm. Compared to the placebo arm, it was a median 25 months. So median follow-up of darolutamide 25.3 months were there, and placebo group it was 24 months. With the hazard ratio, if you see that for the radiological progression-free survival, it is good, 0.54 with a significant p-value. So now coming to see the benefit of darolutamide plus ADT on radiological progression-free survival was consistent across the subgroups, including patients with high and low volume disease. If you see in this forest plot, in terms of the high volume disease or low volume disease, in both the patient has responded and is favoring the darolutamide. High Gleason scores, and it is also favoring in terms of visceral metastasis. If you see, this is also favoring darolutamide. But most of all of the subgroup analysis are showing the benefit. So this is what the efficacy of darolutamide we can see here. Coming to darolutamide plus etomide demonstrated benefit across secondary endpoints. If you see, the key secondary endpoint was the OS. Here you can see the OS has been favoring the darolutamide with a hazard ratio of 0.81. Time to metastatic CRBC, yes, it is favoring it with a hazard ratio of 0.40 with a good confidence interval, you can see. And time to PSA progression is 0.31, and time to initial of subsequent systemic therapy population 0.40. So at the time of primary analysis, OS data are immature. Since OS is a mature, patient will be followed for survival, and then we can comment on the OS data, what that has been shown here. All remaining per protocol placebo patients offered crossover to darolutamide after primary, and this will dilute the overall survival data also, because patients has been allowed for the crossover to the darolutamide. Darolutamide plus ADT delayed the time to CRPC and time to pain progression. This curve is clearly showing with a good hazard ratio of 0.40, that is time to metastatic CRPC, and even time to pain progression, it is showing a hazard ratio of 0.72. Delays in time to pain progression can be of high importance to patients and have not been demonstrated with other AR inhibitors to date. That is a merit point that has been highlighted here. Darolutamide plus ADT achieved deep and durable PSA responses. If you see that 63% of the patients in the darolutamide doublet arm attained PSA less than 0.2 nanogram per ml. This represented a 69% improvement in the time to PSA progression in the darolutamide arm versus ADT alone. So these two cartoons are clearly showing here that how the darolutamide plus ADT has shown the time to PSA progression that is not reached, median not reached compared to the placebo arm, and with a hazard ratio of 0.31. And deeper responses we can see with the darolutamide also here in terms of PSA that is less than 0.2 nanogram per ml. A higher proportion of patients achieve undetectable PSA that is less than 0.2 nanogram per ml with darolutamide versus placebo in both high volume and low volume subgroup. These bar diagrams are clearly showing that in even high volume and even low volume, darolutamide is better than the placebo, achieving the PSA less than 0.2 nanogram per ml. Coming to subsequent life-prolonging anti-cancer therapy, patients with subsequent life-prolonging systemic antineoplastic therapy, if you see here, it is in 32.5% of the patient compared to the 42.5% in the placebo arm. So there is a difference. In terms of docetaxel, if you see, it is 22 point. When you combine that with docetaxel also, so patients who discontinued therapy, you can see that 40%, 45.5% had discontinued also. That's actually significant data we can see here. But in comparison to placebo, it is very less. That is here in the placebo arm, it was 71.7. So if you see that further prolonging systemic therapy, what was used, docetaxel was used in mostly, then abiraterone acetate was used. Later on, enzalutamide, apalutamide, cabazitaxel, and other treatment has been used. So that's how we usually practice in our real world also. Once we have used the ARI of one group like enzalutamide or darolutamide, we convert it to the chemotherapy and abiraterone acetate and all other things. So that has been shown here, the disposition. Incidence of treatment emergent adverse events was similar between the treatment groups, and discontinuation were lower in the darolutamide arm. If you see, it is in 6.1% compared to the 9% of placebo arm. Median treatment duration was 24.2 months in the darolutamide arm versus 17.3 months in the placebo arm. The safety profile of darolutamide in ARA was independent of PSA response and consistent with the favorable tolerability first seen in ARAMIS and ARASENS also. And here also in the ERA note also. So these are the three trials, ERA note, ARAMIS, and ARASENS in different setting for the darolutamide. So the rest of the most common adverse are low and similar in the treatment arms. Fatigue was the one thing that has bothering for this patients here. Yes, anemia was there, arthralgia, UTI, back pain, liver enzyme disturbances, constipation. These are other hot flushes. Yes, definitely pain in extremity. So most of the, even you see the hypertension in 8.5%, but it is matchable to the placebo arm. It is similar most of the time. In fatigue, if you see, it is less even from the placebo, around 5.6% patient compared to the 8.1% patients. So this is what trying to shown here. These are the major side effects that has been mentioned in this chart. The rate of adverse events commonly associated with the ARPIs were similar across treatment arms. That has already shown here. You'd see in terms of hypertension, in vasodilation, flushing, diabetes, and hyperglycemia, cardiac arrhythmias, fatigue, rash, bone fracture, CADs, heart failure, very less, depressed mood order, very less, cerebral ischemia, very less. So darolutamide confers a positive impact on health-related quality of life also, that has been shown in this curve. Extended median time to deterioration, in fact, P total score by 5.1 month versus placebo. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delay in pain progression and overall well-being. This has been published in ASCO 2025. And time to depression, in fact, fee has been shown here according to that. So darolutamide doublet therapy demonstrated clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptom domain. And this was time to depression according to the FACT-P subscale score. So basically, it's better in terms of improving the quality of life of the patient also. That has been tried to shown here in terms of everything. So conclusion is that darolutamide plus DDT significantly improved radiological PFS in patient with MHSPC. Darolutamide showed a benefit across all secondary endpoints. Darolutamide was also able to deep PSA responses regardless of baseline PSA. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social and family well-being, functional well-being, and urinary symptoms. Darolutamide had a favorable safety profile. So darolutamide plus ADT without chemotherapy docetaxel should become an additional standard of care for MHSPC. That's good actually, because we have one more option of additional standard of care, and this trial has proven that benefit. Yes, two merit points, that deep PSA responses as well as the quality of life point has been shown with manageable side effects and all other things. As much as we are going to use this darolutamide in real world, we will be more confident in using it and for the patients as well. So I think this all from my side, and over to organizers. Thank you.
Thank you, sir. So thank you to Dr. Saurabh Mishra sir for decoding aeronaut evidence. So now I welcome Dr. Nikhil Krishna Haridas. Sir is Associate Professor, Department of Medical Oncology, Amrita Institute of Medical Sciences, Kochi. So SAR will be presenting Arasen's trial that is reaching new heights in MHSPC care. Over to you, sir.
Yeah. Uh, Thank you. Thank you, Vinod. A special mention of thank you. On the onset, I'd like to thank the Bayer team for giving me this opportunity. I think a handful of patients, we do have some experience with Arasens. I would request the organizers to share the slides from there and it might be easier for me. Is that okay?
So, yes, sir, yes, I'll share, sir. Give me a minute, sir.
Sure. And a special thank you to Dr. Saurabh for um, starting the proceedings.
Thank you, Dr. Nikhil. Thank you.
So 1 minute, sir.
No issue.
Sir.
Thank you.
Okay.
Yeah. Yeah, so we'll be discussing about the metastatic HSPC care in a broad overview. The original plan was to start in a sequential fashion and then introduce ARA-NOT. We have seen that ARA-NOT, that is our novel next-gen ARPI darolutamide with ADT, is one of the newer standards in an metastatic hormone-sensitive setting. We were using previously NMCRPC, then came the particular data we are talking about. Next slide, please, Vinod. These are standard. My disclosures and disclaimers are that the slides are provided by Bayer. Next slide, please. Yeah, I think this has been discovered. We know that the landscape of the prostate is a very we are diverse set of disease. You have the prostate localized disease which may remain without treatment for a very long time, and we have the patients with the metastatic disease, very aggressive nature, probably with the neuroendocrine differentiation or a small cell variant, etc. And in a metastatic setting, when you have a patient, you probably want them to, keep them in a hormone sensitive setting as long as possible, because we know that once they reach CRPC, whether they are metastatic or non-metastatic, it is generally leading, it's a terminal disease, and that would be the cause of death. And as mentioned earlier, in terms of, I think I may need a small help from you, Vinod. You can minimize the video thing, that small box from your end, because it is yeah, perfect. Treatment of the OS is only around 5 to 6 months in a lot of these patients. The improvement, whatever we had, so it is very important that we intensify the therapy in the hormone sensitive setting. Next slide, please. Fine. Please go ahead. So with that probably gave the intense, the initially ADT during our training time. ADT was generally considered one of the standards for uh, you know he- hormone sensitive setting, and then we add chemotherapy from the old gated trials of docetaxel in the CRPC setting. Once the chartered came out and latitude came out, we knew we had to treat these patients very aggressively. And then when the stampede also came, where the control arm of stampede, the focus should be on the control arm of stampede, where we had generally, if you look at the proportion, I mean, the event-free proportion, there is a huge difference between patients who have received docetaxel versus patients who were on ADT alone. More number of progression, more number of events occurred in this subset of patients. Next slide, please. Yeah. So if you look at the Stampede arm about regarding docetaxel, they did classify the patients based on the old chartered and the latter classification with less than 4 bone metastasis and patient subgroup with more than 4 more than equal to 4 bone metastasis as high volume and the less than 4 as low volume. Here we found that the addition, definitely, if you look at it, ADT versus ADT plus docetaxel, there seem to be a benefit of adding, the what are the standard of care. Addition of radiation in a low volume disease, definitely you can see the blue line is the addition of radiation in a low volume disease. These definitely had and keep in mind the patient did not receive metastatic directed therapy. They only received radiation to the prostate in the Stampede trial, prostate bed. You can see very clearly there is a benefit with a good hazard ratio of adding radiation, which improves the overall survival. It also improves the failure-free survival also. But if you look at the high volume disease, there doesn't seem to be much difference in the curves. So addition of radiation is not particularly useful in this subset of patients. Next slide, please. Yeah, so this is I think a very nice, a timeline of the improvement with the systemic therapy. As I was mentioning, the original getting AFU trial, which looked into the hormone sensitive setting, which led to the actually formulation for charter. A lot of the common investigators were there. In charter, addition of docetaxel to ADT improve the survival in HSPC setting. Similarly, Stampede Arm C Army data came out about docetaxel. Arm G about abiraterone came out. The low volume plus abiraterone plus radiation does help improve survival. In latitude, again, high risk versus low risk classification. High risk, they did better with initiation of abiraterone along with ADT in the hormone sensitive setting. This was followed by already, as Dr. Saurabh had mentioned, the ARCAS and the Titan. And you had the Enzamet trial. All these are hormone sensitive setting. Then came the era of Peace 1, followed by the Arasens. Both these trials definitely were landmark trials. They divided the patient based on high volume, high risk, low volume, low risk, and all the combinations in between, especially the Arasens. And we were finding that we're improving the hazard ratio. You can say overall survival hazard ratios kept improving over time. So how do we select? We have a lot of options now, and how do we select? There was a time when only docetaxel was the approved thing. Now we have all the options. How do you select our treatment is the question what we are facing at the moment. Next slide, please. So again, coming to charter, as I mentioned, high volume versus low volume patients were divided into, and very clearly low volume did not benefit probably much in this particular trial with the addition of chemotherapy. So they had the requirement that patients who had high volume disease in form of 5 or more lesions or any bone lesions outside the pelvic spinal axis, all classified as high volume. Any visceral metastasis are high volume automatically. And these patients went on to receive chemotherapy. You can see the median OS was 51 months versus 34 months with ADT alone. So great, huge difference and clinically significant and statistically significant improvement. Here I have almost adding on more than 1.5 years. Next slide, please. Coming to the latitude, again here based on the Gleason's, the PSA, and also the bony metastasis, they classify into high risk versus low risk. As you can see in the high risk, adding ADT, abiraterone to ADT definitely improves the survival. Again, similar to chartered, you had 33 months, 36 months with the ADT alone versus 53 months in the abiraterone arm, hence establishing abiraterone as one of the other non-chemo options which are effective in it. Of course, one particular point which everybody do bring out is regarding the usage of, what do you say, usage of steroids. And please, next slide, please. One particular thing is about usage of steroid, because originally it was 10 mg, that is the recommended prednisolone dose. But practically at this point in time, with almost close to 10 years of usage of this drug, even we know that even some lower doses help reduce the edema, hyperkalemia, all the adrenal related issues. So even low doses of steroid is a reasonable thing. And very important that placebo crossover to abiraterone also had the same amount of toxicity. So the drug had quite a bit of toxicity which are manageable, as we know in our day-to-day practice. Next slide, please. Titan was the approval for apalutamide in this particular scenario. Again, as you can look at, both PFS and OS had a very healthy hazard ratio. There is a reduction of risk by more than 50% in terms of progression when you add apalutamide. Also, for more than close to 40% reduction in risk of death when you look at overall survival. And the hazard ratios were still maintained in whether it was a low volume or high volume. So apalutamide became one of the go-to drug for any patient, high irrespective of volume risk in a metastatic HSPC. Next slide, please. This is again the data from Enzamet, again very clearly similar to what we are seeing with the ARPAs. Very good clinically significant survival benefits, almost similar as Titan trial. Again, of course, here with the hazard ratio probably in a high volume disease is not as good. So that's one consideration that we can think about abiraterone or apalutamide if you instead, or a darolutamide as per aeronaut rather than enzalutamide for high volume patients. Next slide, please. So this led to the thought, what happens? Can we keep the patient longer in a hormone sensitive state, and will adding ARPI plus chemotherapy help in improving outcomes? Next slide. So for this, I would say piece one, it's a complicated trial. People who are involved with the Stampede, like Karim Fisasi, all that same group are involved in this. This included a lot of de novo metastatic patients, so there's no recurrent metastatic patient, unlike the trial which we are going to further talk about. Here, the design is 1:4, 1:1:1:1 ratio. You had patients with the standard of care at that time, that was the ADT plus docetaxel, and patients went on to receive abiraterone in a particular arm. So the control arm was ADT plus docetaxel. In certain patients, especially before the charter trial they have started enrolling. Those patients were on ADT alone as a standard of care. But once chartered came out, they shifted to ADT plus docetaxel as the standard arm. Next slide, please. Again, I think this is very important to basically this particular survival curve encapsulates what we see in the real life. Low volume disease, probably not that much significant. You can see even the crossing over of curves. But if you look at the high volume disease, there is definitely a benefit. It added a median survival of, in a high volume disease, the combination of abiraterone plus docetaxel did give a median survival of 5 years compared to the standard 3 years which we were seeing before. So they're definitely an adding on of survival. So this definitely proved that a triplet therapy seems to be useful. Of course, very clearly it is demonstrating there's no benefit in a low volume disease. So we can stick to a double modality, either abiraterone or a docetaxel rather than combination. Next slide, please. This brings us to the Arasens trial. It came out in 2022. Probably we have used this protocol for a handful of patients, maybe 10, 15 patients and some experience at the moment. This included metastatic HSPC, both de novo and recurrent disease were included in the study. Stratifications were done based on the the extent of metastasis, alkaline phosphatase level, etc. So basically, the control arm included docetaxel. The experimental arm was darolutamide for till progression or unacceptable toxicity. Primary endpoint, which is good for any metastatic disease, is overall survival. Next slide, please. And majority of the patients in both arms received 6 cycles of docetaxel, and in real world also we are able to deliver the 6 cycles, whichever protocol that we choose for, without much issue. That being said, if you look at the overall population and the survival, at the time of analysis at 51 months, darolutamide, the median overall survival is not reached, whereas with placebo it was around 48.9 months, which seems to be obviously better than ADT alone. The hazard ratio is healthy at 0.68% with significant p-values. Next slide, please. If you look at the subgroup analysis, both high risk and low risk as per the latitude, there is a benefit of adding darolutamide to docetaxel. And all these are healthy survival. You can even see that in the, of course, low volume, both control arm and the triplet arm did not reach the median survival. Next slide, please. What about secondary endpoints? I think it's very important to keep in mind. I think one of the important thing is the time to CRPC. With darolutamide, very significantly, you're able to delay CRPC. You can see the median is not yet reached. More than 64% risk and reduction to CRPC over docetaxel alone. Again, similarly, all the other endpoints such as time to subsequent neoplastic therapy, time to first skeletal related events, time to pain progression, all these, the addition of darolutamide definitely added a benefit. More importantly, I think the delay to CRPC is what adds on to the survival benefit in this particular scenario. Next slide, please. Again, this is something with regards to PSA response. As you can, generally what we have found, a lot of the patients are able to reach, within 3 to 6 months, the PSA of less than 0.2 in the study, which is pretty, we all know that the PSA kinetics is also an prognostic marker. Sharp fall in the PSA from the baseline at the start of treatment does indicate a better prognosis. So darolutamide did definitely help that, and my personal experience also seems to indicate a faster fall in PSA. Next slide, please. Yeah. Again, similar things, time to PSA progression, etc. If you look at the people who had undetectable PSA at the end of 36 weeks versus those who had a detectable PSA, as I already discussed, the time to PSA progression much delayed. And if you look at the overall survival also, the undetectable group are doing well. So that also is a very important factor in determining what we choose for upfront patient. Next, please. Fine. I think it's repeating the same thing. Next slide, please. So this is regarding the low volume HSPC. I think I would put it like this. I would still consider using Arasen's protocol in patients who are high risk by latitude but low volume by charter. Definitely there seems to be a benefit. Even here, if you look at it, the low volume patients did have a survival benefit. Probably the quantum of benefit is not as much as compared to the high volume and high risk patients. Next, please. So what are the factors do we take into consideration? I think all of us have been using triplet for some time now in treatment of metastatic prostate cancer. Generally, very first thing we look at is the patient fit for chemotherapy or not. Most of the times in our OPD, we're not able to do a comprehensive geriatric assessment. We run the G8, or we use one of the car was one of the short cut methods to assess both toxicity and likelihood of doing a CJ detail. Of course, as I mentioned, high volume, high risk, the priority if patients fit to give a triplet therapy. This will help cover for the likelihood of some hormone insensitive clones also. And will always in prostate cancer, one question comes, will prostate cancer be the cause of death? We know the high risk, high Gleason patient, aggressive disease. Indian population, definitely prostate cancer is a much more aggressive disease than what we see in the Western population. Average age group seems to be 5 to 10 years younger than what is seen in the Caucasian population. Lot of Gleasons 4 and 5. A lot of variants, lot of ductal disease also in the absence of a BRCA mutation, intraductal carcinoma. So docetaxel, now one important question which Dr. Saurabh brought up, do we really need docetaxel with the Ranaud data, both high volume, low volume, risk, etc. All this seem to be stable. Do we really need docetaxel? I feel at the moment the answer still remains. I think I would consider a triplet in this setting. And of course, patient choice after giving the appropriate information is very important. Next slide, please. Oh, thank you. With that, I would like to hand over to the organizers, and I would like to thank them for sharing my slides. Over to you, Vinod.
Thank you, sir. So thanks a lot, sir, Dr. Nikhil Krishna Haridas. So thank you for presenting Arasan's trial, sir. So next, I would like to welcome Dr. Nikhil Himtani, consultant medical oncologist and hematologist, Batra Hospital and Medical Research Center, New Delhi. So sir will be presenting case presentation, real world case study. Over to you, sir.
So thank you, Team Bayer, for giving me the opportunity. So I would request the organizers to kindly share the slides.
Ravi?
I think Vandana have a slide for.
Sorry, Vandana?
Vinod sending slide to you.
To me.
Yes, yes.
Sir, please give me a minute, sir. I'll just share it now. Sir,
Yeah, can you make it full slide?
one second. Okay, sir.
Okay. Yes, yes. So good evening to all my dear colleagues. I would request Dr. Saurabh and Dr. Nikhil, if they are there, we can discuss, and we can also learn from their experience regarding management of metastatic hormone-sensitive prostate cancer. So, Dr. Saurabh, are you there?
Yes, yeah, yeah.
And Dr. Nikhil, I hope you're also there.
Yeah. We are there.
So, thank you. Next slide. So this is the case which we'll be discussing about. So he's a 63-year-old male with a history of diabetes mellitus on oral hypoglycemic agent, and patient has history of ischemic stroke on ecosprin. So patient presented with a complaint of increased frequency of urination, burning micturition with poor flow of urine, along with backache, and the patient had a good performance status of PS1. So I would like to ask Dr. Saurabh, so how do you generally proceed in such patients? So most of these patients generally do present to urologist and are diagnosed, come with a diagnosis of CA prostate. So what is your approach if a patient comes to you with such symptoms? How do you work the patient up?
So if patient directly landed up with this symptom, that is LUTS. So I will evaluate with the basic investigations of urine first, and obviously I will involve the urologist upfront in those patients because they are old patients. I am suspecting some benign prostate pathology or even the malignant whatever. I will include urologist and send the basic investigation and let them follow how the. Yeah.
Okay. Okay, next slide. So PSA was done, and it was very high. It was more than 300, and ultrasound was done, which showed basically a prostatomegaly with significant postvoidal residual along with heterogeneous ecotexture. So generally this is, as mentioned by Dr. Saurabh, we generally do the serum PSA and we do the ultrasound KUB, and when there is a suspicion of prostatomegaly with heterogeneous ecotexture, it points out to a prostatic pathology along with raised PSA. So in such patients we do trust guided prostatic biopsy. So in this patient, trust-guided prostatic biopsy was done, which showed a prostatic adenocarcinoma, and Gleason's was 4 plus 4, 8. And later a PET CT was also done, which showed PSMA avid prostatic mass with multiple bony metastases, more than 4 bony metastases to be precise, and patient had abdominopelvic lymph nodes. So, Dr. Nikhil, what is your approach to such patient who is having de novo metastatic CA prostate with a high Gleason score with a well-preserved performance status?
Yeah. I think both, if you look at the risk wise and the volume wise, this will come as a high volume, high risk patient. One concern would be, does he have any residual neurological deficit from his ischemic stroke? But it looks like he doesn't have it. So
Yes.
definitely in this patient also, we would consider an Arasens type of protocol, a triplet, rather
Okay,
than
so
going with a doublet.
doublet. Dr. Saurabh, how do you really decide regarding doublet versus triplet? What factors do you generally look at whether deciding which patient is a candidate for doublet therapy and which patient is a candidate for triplet therapy? So what factors do you see,
So
doctor?
yeah, so if you see that doublet versus triplet, why this have come? Because triplet has definitely increased the survival. We are seeing that. The only question
Yes,
is who are the patients who can tolerate the treatment and how can we select the patients?
yes,
As Dr. Nikhil has mentioned, high risk and high volume disease do
yes,
qualify for the triplet therapy. Now the consideration is the patient related factors, that whether they are
yes,
able to tolerate all the drugs or not. The good
yes,
part is with this that initially we have only abiraterone. Abiraterone does have a more toxicity, we all know, in terms of
yes,
many with the steroid. Even the patient is diabetic also. Definitely the steroid concern may be there. Definitely, I have seen sometimes the blood sugars rises high in even
Yes.
510 milligram prednisolone. So now good part is now we have a good drug that is darolutamide also that we can combine with the triplet. So triplet versus doublet, according to the patient fitness, patient-related factors are more relevant. Yeah.
Yes, yes, very important, rightly mentioned. So both factors play a very important role. Both patient-related factors as well as tumor-related factors dictate whether we should consider for a doublet therapy versus a triplet therapy. So we have the option of piece one, that is abiraterone, as well as the Erasense of darolutamide. So what is your preference in your clinical
Hmm.
practice?
So till now, obviously, because we are much used to abiraterone since many years, we all know we have started with the piece one. But
Yes,
I have what my experience is out of 5 patients, if I treat in a month of the prostate, this high volume, 3 patients definitely have a severe side effects, and they have
yes,
some side effects. We have to modify the dose of docetaxel, or we have to stop sometime, or we have to prolong the duration of the treatment. Anything that can happen, the duration of chemotherapy cycles has to increase. But with the derutamide, what I have used in the patients, they are able to tolerate, not a tough regimen. So right now, I am shifting my practice gradually towards more derutamide as we have a now more evidence and we are getting
yes,
used to it multiple times. Yes.
yes. And Dr. Nikhil, what is your preference? So triplet therapy, abiraterone versus darolutamide for high
So,
risk, high volume disease.
so in our center, we had a poster about the triplet therapy as such. Of course, in that we found all of us combined had probably 15 patient for some 80, 90, piece one protocol patients. So that would be the ratio for every five,
Okay.
six patients, or maybe every 10 patient, one patient might go for obvious reasons on Arasens, other most are on piece one. I agree with Dr. Saurabh that because of the nature of abiraterone, because of its enzyme inducing nature, there is quite a bit of toxicities, especially if the patient is on polypharmacies. There are quite a bit of liver toxicity while on docetaxel during the chemo phase. You might suddenly hyperkalemia, the hypokalemia might creep up on you. Patient may come with the hypokalemic paresis, etc. I mean, I've seen this is a scenario that happened to me, and I had to shift over to another drug. So we should anticipate these problems. That being said, for a fit patient, there are even 77-year-old who go through triplet therapy. All of it, as you mentioned already, one factor is about the patient ability to take docetaxel. That's the first consideration when you're looking into therapy, and then the other factors to customize and select the best appropriate treatment for the patient. The much polypharmacy goes very well with the darolutamide, especially a lot of the common drugs do not have any interaction, so toxicity is due to that less. That's probably the reason why we see less. I also agree with Dr. Saurabh. Whatever Arasens are given, it seems to be, I don't know, it's a bias or something, it seems to be smoother than the abiraterone docetaxel combination, especially these what we toxicities in terms of endocrinopathy, electrolytes, and probably even liver also.
So,
So
what I seem to get from both of you is basically that darolutamide has obviously shown improvement in delay to CRPC and improvement in PFS as well as OS, and it is much better tolerated as compared to abiraterone because it has to be coupled with steroids, and the risk of hyperglycemia and steroid-related multiple side effects can occur during the course of therapy. So, coming,
one concern, Doctor, both of Dr. Nikhil, what my experience says, like when we are using the triplet therapy in those bony metastasis patient,
yes,
my experience is saying since last I have noticed, I started noting actually last 10 to 15 patients, and Dr. Nikhil has mentioned that he had a lot of patients on piece one. The
yes,
patients who are having a severe bone pain of the spine, those patients are not very much responding on the abiraterone plus chemotherapy arm I have seen, what my experience is. And somewhere, if we don't go for some local therapy, ultimately the PSA will respond, everything will be there, but that patient's pain will not resolve. And we have to go either for some local radiation therapy, or even in that case, worst situation, we have to go for the neurosurgical treatment also. That's what my experience says. Maybe what yours, I don't know. And as we are going to use delutamide more now, we can see that whether this is a difference, that the pain control was shown in delutamide, that it is better. PSA deeper response is also better. So I don't think, but I just want to share and want your experience that how you
Yeah,
feel that in.
I completely agree with you. So I have also used now darolutamide. I have some experience, and what I feel that it is a very well tolerated drug, and the responses also are much deeper and much better. Specifically with regarding to bone metastasis, as you have mentioned, yeah, I do
Mhm.
agree that patients tend to achieve a rapid response as compared to Abratron. This is my observation as well. Dr. Nikhil,
Yeah.
your
Exact
opinion?
same observation. So we have to obviously, I mean, I don't think a lot of these patients, we start the chemotherapy almost immediately. We start the ARPI, and by the time we also look at it, we add symptomatic patients, as mentioned, this completely destroyed this thing, spinal cord involvement. We are going to give
Yes,
some radiation. I do agree, Abratron, I mean, combination does seem inferior, but we definitely have to add some local therapy for that. Regarding what all of you have told, and it is also my observation that PSA kinetics and the combination of aracins, there seems to be a sharp fall.
yes, sharp.
Or, and touch wood, at least, I mean, there has been in the total number of patients, there are 4 consultants. I mean, there may be a referral bias, so I see a little more of prostate. We have our own internal this thing, but that being said, touch wood, I have not had a progression of a patient who's on darolutamide aracins as of
Yes.
now. So this is total 3 years of starting using. So even the first patient is still in HSPC as of now.
Okay, so thank you, Dr. Nikhil, for giving your input, valuable input. So coming back to the case, so this was a case who had high volume, high risk disease with a good performance status with the Gleason's of 8. So next slide. So this was the baseline PET. You can see almost all bones are involved. Cervico, dorso, lumbar, vertebra, everything is involved. So it's a high volume disease. So so the impression was it was a de novo metastatic prostatic adenocarcinoma with multiple bony mets and abdominal lymph node mets, and it was a high volume disease. So next slide. So the patient was started on triplet therapy in view of high volume disease, and as mentioned, patient-related factors do play a very important role. Since the patient had a good performance status, he was eligible for the triplet therapy. So he was given ADT with Degarelix and along with Abratron. 1000 mg, and along with that Visolon was given, and docetaxel based chemotherapy was also given. So the triplet therapy was initiated. Post 4 cycles, patient responded well with drop in PSA from 323 to 2 nanogram per ml, and after 10 cycles of docetaxel, the PSA fell down further to 0.04 nanogram per ml. PET CT was done post 4 cycles, which showed a partial response, and after 10 cycles, there was literally a metabolic complete response. And docetaxel was stopped after 10 cycles due to poor tolerance, patient having severe fatigue, myalgias, neutropenia, and anemia. So the patient was continued on doublet with ADT along with Abratron and prednisolone. Next slide. So we can see that this is the baseline PET before treatment, and after post 4 months triplet therapy, we can see significant partial response with only a single lumbar vertebra having PSMA avid disease. So the patient had a significant partial response and relief of symptoms. Next slide. So nearly after 7 to 8 months of Abratron, the patient had poor compliance with OHA as well. So patient had symptoms of dryness of mouth, increased thirst, and increased urination. His HbA1c was done. It came out to be 9.7, and an endocrinologist review was taken and was advised for escalation of OHA. And in view of poorly controlled blood sugars, so Abratron prednisolone was stopped and patient was switched to enzalutamide. I would like to ask again, Dr. Saurabh, your experience with Abratron. How is the side effect profile, and how frequently do you encounter worsening of diabetes in your practice?
Actually, not a much. If I am aware that yeah, it is going to be
Mm,
cause this hyperglycemia as well as poor control of the diabetes, I do start my counseling when it's the treatment to control the diabetes, and whatever the measures involve the physicians as well for the diabetes management, endocrinologist as well, dietitians as well, some type of not totally, but a lot of things to control the diabetes. So right now it's not very tough. Yes, some very non-compliant patients does have these type of things, but not a major problem. It can be managed actually.
Hypertension, how frequently you're observing
Yeah, so
hypertension?
hypertension, not much frequently actually, and most of the time the patients are already on some antihypertensive in most of the older
Antihypertensive.
patients. Yeah, so sometimes we need to increase the doses and anything, and that can be managed. It's not a that any patient has not landed up of any emergency situation or
Yes,
accelerated hypertension or that because of a veraterone. So
yes.
it's not like that. Yeah.
Dr. Nikhil, your experience with abiraterone prednisolone combination, the side effects.
I think now since we have been using it, same as mentioned by Dr. Saurabh, sugar suddenly can creep up upon you. 2 years we'll get complacent, then third year the patient comes with all issue with hyperglycemia. Hypertension never has been much of a issue. I think because we are aware of it's manageable. Of course, some dyselectrolytemia and all can happen. Then some very
Hypertension.
rare issues such as some myopathy secondary to by the steroid induced
Steroids.
myopathy,
Mm.
etc. Also, because as this is the probably the most commonest ARPI we are using due to the factors including cost and good generics. So we are going to see all the other rarer side effects also, and a lot of them seem to be due to the steroid. Of
Yes.
course,
Few experiences I have, Dr. Nikhil, want to share.
Mm.
Patients were landed in sepsis sometime because of XYG reason, urosepsis or whatever, and the patients land up to with some hypotension and everything. So we should keep our mind and keep our staff trained as well that patient is on chronic steroid. We have to start with some hydrocortisone or that initially when the patient landed in ICU, apart from antibiotics and the vasopressors also. Because I have seen
Yes.
few patients, they are not going to respond until and unless you give a hydrocortisone or something to the patients.
Yes, yes.
So
Basically,
this has
abrupt
to be.
stoppage of steroid, basically.
Because they have a
Yes.
chronic adrenal access
Yeah.
suppression is there,
efficiency.
and that has to be taken care during especially of sepsis and stress situations. Yeah.
Yes. So yeah, very important point as Dr. Saurabh mentioned. So this patient was, in view of poor glycemic control, was switched to enzalutamide. His PSA remained under control. It was 0.02 nanogram per ml. Next slide. So after nearly 7 to 8 months of enzalutamide, patient started having moderate fatigue, not relieved by adequate rest. The blood parameters all were repeated. It came out to be normal. There was no anemia. Sugar was under control. All electrolytes were within normal limits. Thyroid profile was euthyroid. Vitamin D3 was normal. His disease seemed to be under control with PSA of 0.01. PET CT showed a stable disease. So impression it was either ADT related fatigue or enzalutamide related fatigue. So again, my question to Dr. Nikhil, I would ask. Fatigue, I think it is a very common side effect when the patient is on prolonged ADT exposure. So do you consider for some ADT breaks or you consider for continuous ADT?
I do. I am actually. I think even we have the recent A Dream trial from the ASCO abstracts, where intermittent ADT is the way to go forward in these patients.
Mm.
Probably all the high volume disease patients would not qualify for it. We have to be very careful in a high volume setting like this whether we really want to give a ADT break. That be said, there are quite a few patients who with the low volume disease with some metastatic directed therapy also, where lot of times we have got intermittent ADT. We are able to give them a treatment free break for 1.5 years, 2 years also
Okay,
before
in
the
high
PSA
volume disease as
progress.
well? In
High
high volume
volume I
disease?
have done. So this is a little tricky. So it is restricted to patients who have a lot of maturity and understanding what are the issues and all that. So very few. There are a few patients high volume who had a very, but one patient particularly had a you know the sexual dysfunction angle of it.
Yes.
So he
Yes.
really wanted to stop it at a high volume with very good control. At that time it was only a doublet. At that time we were able to give in some treatment break, but once we had to restart the ADT, he became CRPC within 6 months. So that may
Okay.
be the nature of the disease. Very few, maybe 4 or 5 patients with high volume on. So most of them would be on that. Enzalutamide, for me, hearing the semiology, 2 to 3 months, I mean 3 to 6 months of enzalutamide onset, then fatigue. I know the ADT fatigue sets in at the third and fourth year of treatment, but the 6 months is a classic for enzalutamide, and we know enzalutamide probably in certain populations are much more poorly tolerated drug than abiraterone, prednisolone compound.
Yes. Yes.
So I would blame the enzalutamide for the fatigue.
Yes. And Dr. Saurabh, your take on continuous ADT versus intermittent ADT for high volume disease. Do you consider for stopping ADT if the patient is having ADT related side effects?
In CSPC, I would not like to choose this approach still now, but in CRPC, that bipolar androgen therapy has coming into picture where you will circulates or oscillates the testosterone level between high and low. So sometimes you are giving the testosterone injections also. The bipolar androgen therapy is coming in the picture right now for. But CSPC, I don't go for the break, but I will search first the other causes of fatigue also, not because of the conflict only the drug. Maybe patients have many times we don't bother about the magnesium levels, vitamin D levels, calcium levels. We should check all these. I have found few patients who are deficient in vitamin D as well, who are deficient in magnesium levels
Yes.
as well. You can correct. But I
Yes.
think I will counsel my patient also that rather than stopping, try to manage it with some other non-pharmacological methods as well. So as in practice, it's theoretical more, but practically I don't stop in most of the
Yes.
patients. Yeah.
So very point well taken, very important. So if the patient is having fatigue, we should rule out other causes as well. So we do not should not blame the drug first. So in this case also the workup was done, and the vitamin D3 electrolytes were all within normal limits. So it was suspected to be either ADT related or enzalutamide related fatigue, which was not being relieved by adequate rest. So next slide. So, in this patient who was having moderate fatigue, so enzalutamide was stopped and patient was switched to darolutamide 600 mg twice daily since Jan 2025, along with continuation of ADT. So ADT was not stopped in view of high volume disease and Gleason's of 8. And so patient's fatigue improved drastically. So 2 weeks post cessation of enzalutamide, and the PSA remained to be sort of under control, and the PET-CT was done around 6 months later, again showing sort of a metabolic CR, and patient continues to be on darolutamide and ADT till date for past 1.5 year, and patient is maintaining a good quality of life with disease in remission with PSA under control. So your experience, Dr. Saurabh and Dr. Nikhil, with
So
darolutamide as compared to enzalutamide?
So I have not shifted like that as of now, but yes, now this is giving a hint also. I have tried one patient actually, just a practical experience, not a recommended one. I have used in the patient even in CRPC. I am telling you on this forum because
Okay.
patient was already some treatment and he was so bedridden that no treatment was responding. They came to me and asked me, okay, something to be written. So I searched what I should give. And
Mm.
he was already on enzalutamide, not responding. So
Okay.
I prescribed enzalutamide to and suddenly after 21 days he came back with good PSA responses, betterment in pain and everything. Somehow patient was survived because of some other complications like cardiovascular events, but at terms of the prostate malignancy, it has responded. So I think that this is a practical solution right now as this case has been shown here. If it is all really done in the real world, it can be we can transit like this, enzalutamide to darolutamide in fatigue patients also, even in patients who are not tolerating. So I think it
Yes.
can be practiced actually. Yeah.
Yeah,
So
it can be, and it is probably something we are doing. We are offering to the patients. Initially, practically, cost-wise, if you give them option, they'll select the lesser cost options.
yes, I think
But
that is
when
the
the
major hindrance.
yeah, when this
Yes.
fatigue sets in, especially in this scenario, we suspected enzalutamide because it crosses the blood-brain barrier,
Yes.
and we shifted to darolutamide. You had this is a classic case where it is we are proving also that your and also the response to PSA, which was at 0.2 stable, 0.1,
Yes.
0.2, did
Yes.
further drop down once you had started it. This fall in
Darolutamide.
PSA is seen in darolutamide much more than combination with abiraterone.
Yes, yes. So with that, I think I would hand back over to the organizers and any other questions uh, from
I think
the participants.
lot of things you have discussed already, I think. If there are any questions. Yeah.
Yeah, thank you, sir. So we have right to the end of the meeting. So thanks a lot to all the three speakers. So I would like to thank all the doctors who has joined us as a participant in the meeting, and our three eminent speakers, Dr. Saurabh Misra and Dr. Nikhil Krishna Haridas and Dr. Nikhil Hemtani, who has given a good presentation on Aronaut evidence and Arasan's trial and also the real world case study. So thank you, sir. Thanks a lot for
Thank you.
sharing the thoughts. Sir. Thank you, sir. Thank
Right.
you,
So
Nikhil
yeah.
Dhani, sir. Dr. Nikhil Krishna, sir. Thank you. And Dr. Saurabh Mishra, sir. Thank you. Thanks a lot, sir.
Have a great
Bye.
evening.
Thank you.
Thank you
Thank
and
you.
good
Bye.
night. Bye.
Good night, sir. Good night, sir. Thank you. Tech team. Tech team. Tech team.
And I think tech team is there. Any person from tech team is there?
Yeah, tech team is there, but there is no response.
Okay, Vinod. So thank you for all of.
Yeah, Ravi, thank you.
Uh,
Thanks a lot. Vandana.
Thanks all doctors who have joined this meeting and giving your valuable time for us. Thank you. So now we can close. Vinod?
Yeah, we can close. Yeah, once tech
Okay.
team closes, now it get closed. Tech team.
Can I call to the tech team? Vinod?
Tech team. I don't have the number of who is.
Okay, let me check.
Yeah, check please.
I think Dhriti is not responding on my phone. Okay.
Tech team.
Vinod, Dhriti is not responding.
Okay, so
we can leave.
yeah, we can sign out. We can do it.
Okay.
Okay, Ravi. Yeah, bye.
Bye. Thank you.
Tech team. சிவா, நீங்க இன்னும் லாக்அவுட் பண்ணல சிவா. ஒன்னு லாகின் ஆயிருக்கேன். டாக்டர் ராஜ். அது ஆயிருக்கு. ஆ ஆ ஓகே. டேய், ஒரு நாள் ஆங்க. ராஜ். ஓகே ஓகே, லாக் அவுட் ஆயிடுச்சு. இப்பதான் கட் ஆச்சு. இப்பதான் கட் ஆச்சு. Tech team, hello. Tech team.